Hello, everyone. Thanks for coming to the latest Closomat and the Occupational Therapy Service webinar. This is our last series within this academic year, and we're excitedly planning for webinars from September. So we look forward to seeing you again then. But thanks so much for coming to this one, which clearly you can see is Arthritis, Activity, Impact, and Maximising Independence. If any of you have been to these webinars before, you probably understand the format. Or what I try to get across in these webinars, in that there'll be some information in here that is a refresher. There'll be some that is brand new to you. And if it's neither of those things, then hopefully there's some points within it that will at least stimulate some sort of reflection and allow you to take some sort of snippet away to apply the practice or to reflect on. That's really what we're after. CPD that allows you to reflect, that challenges, and ultimately maximizes the outcomes for the clients that you're working with. We're going to try and develop a greater understanding of arthritis and its impact on occupational performance. We're going to consider activity analysis and the impact on recommendations. We're going to review design and modifications to maximize independence and have a look at the practicalities of those things that we're good at thinking about and sometimes the things that we're not so good at thinking about. And within that, we're going to reflect on some legislation and guidance to support the clinical reasoning and how we go about getting funding for some of those things. So let's start by having an introduction to arthritis. So this might be one of the things where it's just a bit of a refresher. If you're new to the profession or you've never worked with anyone with arthritis before, some of these things might be completely new for you. As occupational therapists, it's about making it clear that the diagnosis isn't the be-all and end-all. It isn't what we are focusing our intervention on. Clearly, as a healthcare professional, a healthcare profession who don't work in the medical model, work in the social model, our interest is in the person, their performance, their engagement with the task and the environment. However, if we don't understand a condition, we are less able to evidence-base our recommendations. We are less able to understand the impact and potential future impacts of those conditions. And with something like arthritis, or with previous webinars we've done around something like Parkinson's, if we don't understand the specific diagnoses within those within that medical model, it's very difficult sometimes for us to be able to plan and future-proof and make recommendations that are robust. So that's why I'm starting with, let's take a look at what we mean by arthritis, because it's a general term. So arthritis is an umbrella term for over 100 conditions that affect the joints, causing pain, stiffness, and reduced mobility as a result of inflammation. The most common types of diagnosed arthritis are osteo and rheumatoid arthritis, although others we may come across quite commonly include ankylosing spondylitis, cervical spondylitis, polymyalgia rheumatica, and gout. Some of those are easier to say than others. I'm just listing a few that you might come across that you think you didn't realize were associated or part of that arthritis definition. And we're going to go through some of them in a bit more depth to understand what that means if you have a specific diagnosis. So let's take a look at osteoarthritis. So this is the most common form and it affects over 9 million people in the UK. It can affect any joint, but most likely to affect joints that weight bear or used most frequently. So ankles, knees, hips, fingers, wrists, things that you're using all the time. In a healthy joint, there's a good covering of smooth cartilage which covers the surfaces, but when it's worn or damaged, the repair process can cause deformities, which then impact on structure and causes inflammation. And you can see that on those two images. So basically, when the cartilage is running thin or is disappearing, generally based on age, but doesn't always have to be. It could be because of a specific injury, someone who's played a lot of certain sports when they were younger, like squash, basketball, anything that's kind of high impact. If they've had lots of wear and tear, the bone will try and repair itself, and in repairing itself can actually cause deformities, which then creates inflammation and pain. So that's osteoarthritis. And it's the one, I think, because we most commonly associate it with age, because it's about general wear and tear. So the symptoms for osteoarthritis are joint pain, particularly after rest or at the end of the day. So again, going back to what we need to know about the conditions is if we're aware that after somebody's had a period of rest, so if somebody's been in bed all night, or at the end of the day when they've been engaged in lots of activities, then their ability to engage and function and their activity analysis might significantly change at those particular times. So how we understand their performance at those times is therefore important. It often comes with joint malformation, like I mentioned there before, often reflected in hardness, which is caused by bone growth. So you might see someone with big knuckles, and it's that kind of hardening, that extra bone growth that's been created by an attempt to repair the joint, but actually has a negative impact. And crepitus, which is the name for joint cracking or grinding sounds, I'm sure as healthcare professionals, most of us will have been in a situation at some point where we've been helping someone stand up or been around someone when they've gone to stand up, and you have that grinding sound that just goes right through you, or joint cracks. That's a common symptom of osteoarthritis. But symptoms are likely to improve, certainly in the initial stages of osteoarthritis. Once the person is moving and up and around, it's got creation of synovial fluid, and once synovial fluid is being created, it's within the joint, then there's a bit more lubrication in there, and a lot of those symptoms will dissipate. Not all, but some, and as the condition becomes more and more severe, then less so. But it's good for us to know that once the person's up and moving around, after a period of time, things can start to improve in that specific moment. Now, rheumatoid arthritis is a very different condition. So it affects 400,000 approximately adults in the UK. It's an autoimmune condition, which means that the body's immune system attacks healthy tissue. The main impact of this is joint inflammation, which allows fluid to fill the extra space with the intention of fighting off unwanted infection. So if you think about the body thinks that there's something to fix, there isn't, but it's a false warning. So what it does is it sends fluid to that area to clean it, to provide antibodies to, in the same way that you bleed if you have a cut, it's to wash, and for the platelets to then form a scab, a layer for safety. So it's the same thing, but there's nothing there for it to fix. So because the inflammation is unnecessary, when that inflammation goes down, the joint capsule is still stretched. So it doesn't stabilize the joint as it normally would. So this is happening on a regular basis. You end up with a joint capsule that's incredibly stretched, and the joint itself is therefore unable to be stabilized. So as much as we call it an arthritis, it happens in a very different way to osteoarthritis. So that's why we're starting to get at that detail of, well, what happens? Yes, on a daily basis, we as occupational therapists don't necessarily need to know the anatomical or physiological changes within the joints as part of the arthritic condition. But if we don't understand it, we can't make recommendations that are appropriate in some cases. So the symptoms of a rheumatoid arthritis are a lot greater and often more significant than osteoarthritis. That's not to say that osteoarthritis doesn't have a significant impact on occupational engagement, but rheumatoid arthritis is seen as generally more severe and affects lots of different things across the body. So you've got what you'd expect: the joint pain, joint swelling, and warmth. Don't forget, it's thinking, it's fighting something off. So the brain, the immune system, is creating conditions that it feels like it needs to make you better. And joint stiffness, that's kind of what we'd expect. But additional symptoms include fatigue, weight loss, reduced appetite, high temperatures, sweating, dry eyes, and chest pain, all as a result of inflammation somewhere. So rheumatoid arthritis isn't as limited to the joints that take the heaviest hits. It can be anywhere and everywhere. So what is the impact generally on arthritis on occupational performance? So the pain and fatigue clearly can often affect the consistency of daily tasks. I talked briefly about osteoarthritis there and how that can change throughout the day, from morning to night, and actually optimal performance could be in the middle of those two times. The others will present very differently. So it affects consistency of daily tasks, not just the tasks themselves. So our understanding of people's routines and habits is important, as well as what conditions specifically that they have. Joint stiffness and deformities, so that limits grip, balance, and movement. Psychosocial impacts, it creates anxiety, depression, social isolation. Somebody who's in pain all the time, or whenever they move and struggles to sleep or get into a comfortable position. All of those things are going to have huge psychological and psychosocial impacts. So they impact things like dressing, so buttons, zips, and socks become more difficult to manage. Cooking, using utensils, holding pan handles, opening jars becomes more difficult. And within mobility, there could be difficulty using the stairs, standing still, or gripping handrails. None of those things I don't expect will come as a huge shock or surprise to anybody on there. What I'm trying just to do here is set the scene so we can get into this in a bit more depth. So some of the physical or motor components specific to arthritis would be dexterity, fine motor skills, a potential limited flexion and extension, so ability to stretch our joints out in our limbs and our fingers and then flex them back into grip positions. Reduced weight bearing and force, that's not just through our feet. I don't mean weight bearing and just our ability to stand up, but I mean our ability to carry weight. What force are we able to put through our fingers? What weight are we able to take through our wrists and elbows? That sort of thing. Of course, it includes ankles for standing, but not just exclusively so. And time, so how long are tasks taking to do? How long do they take to prepare for? And how do we build that into routines? Emotional and psychological, so low mood, motivation, anxiety, inability to be spontaneous or to be creative. And sensory, so the touch and pain. So touch, by that I mean it can sometimes change sensation. So is the person managing to temperature check effectively? Do they have any numbness? And how does that numbness affect their perception of where their body is in space, or that particular thing is in space, for example? Pain, pain is incredibly subjective. How do they refer to their pain? How inhibiting is it generally? Vision, so rheumatoid arthritis, like I said briefly earlier, can definitely impact on vision because of swelling and inflammation. So how is it affecting the person's vision? We've done separate webinars on modifications for accessible housing design for visually impaired. So you could look more specifically at that. And psychologically, low mood, motivation, and anxiety. Again, I've put that in psychological and emotional, but they can have different reasons and have different impacts. It's a snapshot, obviously, of activity analysis. It is far greater and far more significant. I'm trying to just highlight how we need to make it specific to arthritis. What specific things are we looking for within that? So that analysis-based approach and recommendations. So based on our applied activity analysis, what are we implementing? What approaches are we putting in? Recommendations does that lead to? So, for example, it may not be that we instinctively go to a rehabilitative approach for someone with arthritis if the issue is specific to arthritis. We know that it's generally long-term and degenerative. Yes, it can have completely different impacts for the individual, but even if it doesn't significantly worsen over a period of time, the chances are it's going to remain there. The exceptions would be clearly if somebody has a knee replacement or a hip replacement or a shoulder replacement. Because of that arthritis, we would then expect that to significantly improve that person's outcomes, but not necessarily through a rehabilitative approach. It's a medical and surgical one. So understanding the conditions just helps us think about what our starting points are and where we focus our intervention. So some of these things, again, they're not going to be brand new, but we're going to get into to them in a bit more depth to understand what's available and what the guidance says we should be doing. Okay, so we're going to focus on two key areas just to highlight some of the issues and some of the recommendations that we can make. So the basics within the bathroom cover these five areas. So shower or bath. So it's always a debate, and it's always different from one authority to the next in terms of the specifications. However, I would say my experience is that we make that jump to showering for adults rather than asking them, why is bathing meaningful to you? So, and there is also some evidence, not as much as you might think, but some evidence around bathing and pain reduction. In terms of domestic sense, there's a lot more evidence around bathing and things like balneotherapy and spa therapy, but not necessarily empirical research data around bathing in a domestic environment. So we tend to lean towards showering from a safety and falls perspective, but it's really important to ask the person what's meaningful to you. Do you what do you do when you're in the bath? Is a bath important to you? If it is, what do you do when you're in there? Because we tend to not go in a bath primarily to wash. We might have a washroom in there, but we do lots of other things. So ask those questions. And within a shower, you're then looking at some of those basics of grab rails, fold down seats, and everything else, lighting, everything else you'd expect. Like I say, we're going to get into this in a little bit more depth in terms of what the legislation says and the guidance says about the designs. But in basic terms, by bathing and showering is one of the features that we would discuss within that bathroom environment. Sinks and taps, it's important for us to think about the depth of sinks. So rather than them just looking pretty, how far down is the person going to have to lean to get into them? What is the height of them? Do they even need to be height adjustable if they're servicing a number of people in that environment? Taps, use lever taps if the person's unable to grip. There are automated options and features. Again, it's one of the things we should be thinking about. Rails, where are we putting them? But not just where are we putting them, what rails are we using? Is the person able to grip them? There are different thicknesses of and circumferences of rails that are available. Do we recommend them, or do we go with the standard regardless of whether the person has Parkinson's, MS, arthritis, etc., etc.? So think more specifically from your activity analysis about, is the person going to be able to grip them, and where do they need to be? Ergonomically, what angles do they need to be at? And that depends on where they more specifically get pain in which joints, and how the person is using that particular space from an occupational perspective. Flooring, thinking about like anti-fall flooring, and thinking about, do you understand the different grades of flooring? We've covered this in the Parkinson's webinar that it might be worth you having a look at, and we've also covered it within a falls webinar a year or so ago, all of which are accessible on the Closomat's YouTube channel. So take a look. But it's not just flooring, it's what flooring. And the toilet, what height does it need to be at? Does the person need something to be able to stand up from and push up through? But if they've got arthritis in their shoulders, wrists, and elbows, how easy is it for them to be able to push up? And how are we managing that? And as always, consider the tasks being performed in the environment and whether it is disabling or enabling the person. Although we have standard designs, people aren't standard and people are never completely the same. So from a basic perspective, let's start thinking about our activity analysis and how that impacts on our design recommendations. So let's see how we back that up. So this is about the bit more depth. And I'm not going to go through every line here, but it's our understanding of, do we know what's available and do we know what it says things like accessible bathrooms should be? Do we know to call it an accessible bathroom, how it should be designed? So, for example, I'm not going to do this for every space in the house because we just don't have the time. I'm just providing a couple of examples here. So, under the Equality Act 2010 and the building regulations, Part M, an accessible bathroom must include, from a space and layout perspective, minimum turning spaces of 1500 by 1500, which allows a wheelchair user to turn easily, door width of at least 850, outward opening doors or sliding doors to ensure that accesses and egresses aren't blocked, non-slip flooring to reduce falls, toilet and support features, so raised toilet seat height of 450 to 480 mil, grab rails, horizontal and vertically placed, not one or the other, positioned around the toilet and the shower, drop down grab rails next to the toilet, flush controls positioned for easy access, preferably on the side of the toilet. So, and the list goes on and on and on. We don't know, not enough time and not enough slides on this webinar to put them all in. But do we know that these things exist? And if we do, great. Let's just see how we can personalize them and make them client-centered. If we don't know they exist, have a look at the legislation to see how it can help you with your accessible design. One thing that always interests me is the activity analysis around standing from the toilet. And from an equipment perspective, we're often re recommending rising armchairs for somebody with arthritis or Parkinson's or some of those other conditions. Whether we can supply it or not is different. I know a lot of authorities and armchairs, but I think very few of us would disagree that they're beneficial. So if we're thinking that would be beneficial, whether we can supply it or not, why do we think that just raising the height of something elsewhere in the house is going to solve the problem? If we're providing someone with that angle to stand, because ergonomically it helps facilitate that transition into standing and moving, why would putting a raised toilet seat or a freestanding toilet frame or something around the toilet ergonomically solve that problem there? It's just something that I often look at and challenge people on. I'm not saying it's wrong. I'm just saying we need to have a little think about that. If you're recommending a rising armchair and then you're expecting someone just to be able to push straight down from a toilet, they either don't need the rising armchair or we need to think of something else around the toilet. So for our clients with arthritis, consider the ergonomics of a stand and the pressures put through those joints. Like I say, if we're expecting someone just to push to stand up, ergonomically, are we supporting a normal stand or a natural stand? And what pressures is that putting that person and their joints under? That's okay, then fine. But if not, there are things we can do to resolve that. So the kitchen, move to a different house, the basics. So the basics would be, we'll be considering lowering wall-mounted cupboards for ease of access. We'd be considering using pull-down baskets or motorized wall cabinet units. We'll be considering oven shelving or pull-out heat drawers. We'll be considering using corner units and rise-fall worktops. Don't for one second think that that picture on there is some sort of perfectly accessible kitchen. It isn't. It's a generated image, and clearly there are huge faults with it. But the idea is they're the basics of what we would be considering. Those kind of high rise and fall worktops, easily accessible, wall-mounted cupboard spaces, things where the person isn't having to carry something that's heavy or hot over for a period of time. So can they slide it along benches, or like I say, is that are there pull-out heat drawers, which are really useful when they're next to the oven, those sorts of things. So they're the basics, and I'm sure you all appreciate those and know them already. But do we know, again, like with the bathrooms, what the legislation says? So under the Equality Act and the Building Regulations Part M, an accessible kitchen must include, so from a worktops and surfaces perspective, it must include a rise and fall worktop. It must include lowered worktops with fixed counters that are somewhere between 850 mil and 950 mil, with a knee clearance under those worktops of at least 700 mil for someone to be able to get a wheelchair underneath. From the perspective of appliances and electrical fittings, there needs to be, so if there are side opening ovens positioned at mid height, so that's 750 to 900 mil with pull out shelves underneath it, which is what I referred to in there. Now, there's a debate about whether those pull out shelves should be underneath or beside. And again, I think that's just based on your activity analysis and what you think's best. My experience of those is that they're predominantly to the side of, but we could debate whether that's right or wrong or not. I think it's a personal thing based on your individual client-centered assessment. And lots of other things there about positioning. So sockets and switches positioned between 450 mils and 1200 mils from the floor for reachability. So lots of things that aren't just about the kitchen, but would be reflected in other parts of the house. And the interesting thing about some of that stuff around accessibility is when you look at some of the documentation, or certainly old documentation, it still talks a lot about accessibility. And I think it's reflected sometimes in practice. We think of accessibility still as it being wheelchair accessible. So taking it back to arthritis, accessibility means accessible to all. It doesn't just mean if you need a wheelchair. Some of the legislation refers specifically to wheelchair users, and lots of it doesn't. But do we understand it? Do we know how to apply it? So an accessible space should consider someone with a sensory impairment, with dementia, with neurological condition, with arthritis. So things like color contrast, task lighting, where switches are positioned, being able to get into recesses under benches if you use a wheelchair. All of those sorts of things should be considered as part of a truly accessible design. Now, in somebody's own home, I understand and appreciate that you may not need to consider all of those things, but understanding them and knowing where to find the evidence for them and what you're asking for is incredibly important. And if we're looking at something like someone with a rheumatoid arthritis, where we know it's going to have a significant impact on their function, and there may well be a time in the future where they're needing something like a wheelchair to get around indoors because of their pain and reduced mobility. And from a future-proofing perspective, we should be able to recommend a truly accessible and future-proofed kitchen or bathroom on that basis. Interestingly, the Occupational Therapy Service have been doing some work with versus arthritis elsewhere, and it's been really interesting getting feedback from the focus groups. Some of the things that we thought might be the most challenging or problematic parts of it, adaptations and equipment, just weren't highlighted by the focus groups. Whereas some of the things we hadn't considered were seen as major areas. So the common themes that came out from them were where and how the equipment or adaptation supports joints. So when you're thinking about even something, let's say, around the toilet, or if you're using the aerolette even, for example, what is their arm positioning on it? How much overhand does it have? Are their hands? And is that supporting their wrist enough? Where is their elbow being placed on it? And is the cushioning enough for them for that? They saw those sorts of details in adaptation and equipment as a significant thing. Controls, or whether you go for button, lever, or switch, and where that's positioned. was really important for them. For most things from their focus group, they were asking for mechanical controls to be on both sides. And I know from an engineering perspective, that's not easy or straightforward, but it was it was common feedback. The button lever, I say I've put level on there, my apologies, button lever or switch was very much around individual. So if you go into Closomat for a Palma Vita, say for example, because someone's having difficulty because of their fine motor skills and their dexterity to clean and wash themselves and dry themselves effectively, then also then think about what controls they have to be able to support that, whether it's like a big firm palm push that can be used with the feet as well, or whether it's an elbow knock, or lots of other different bits of accessories that can be used to support that person. But just think about it on a client-centered perspective. Task inhibiting, so they talked about some of the things that were recommended being installed, either inhibited the task it was meant to support, or it supported that task but inhibited something else. I think that's a really good point, is that thinking about what are the impacts of what we're recommending. It could have a positive one here, but it could have a negative one somewhere else. And they said that activity and support was often inhibited by the knowledge of the person themselves or the healthcare professional. So what was available on the market and how they should go about getting it. And if it wasn't fundable through something like DFG, what support they could get from charities to be able to help them with it. The size of the environment, clearly often in images, marketing images, we see beautiful large bathroom spaces or kitchen spaces that are perfect for a number of adaptations, but the size of the environment was raised by the focus group as one of the most inhibiting factors for them domestically. The lack of future proofing was brought up regularly, and us dealing with what was happening now rather than our understanding of arthritis and what they might need in the future. And when I'm talking about in the future, I just talk about maybe next month or the month after. Some of the conditions can deteriorate so rapidly. Financial support. They talked a lot there about means testing, which isn't something we have a huge control over. But again, and I asked the question a little later about it, what do we do if someone isn't going to get that financial support through grants? And product packaging was something that they brought up in general terms about how if something's delivered, how they even get into it. So there were some really interesting points. Some of those you'd expect, some of them maybe less so. But they're things that it's important for us to know because that should then affect our thought processes, our clinical reasoning for what recommendations we're making. So it's one thing to talk about what modifications should be considered, but how do we justify it through legislation? So we're going to have a really quick look at DFG, Building Regulations, and the Equalities Act. So DFG, if you haven't seen that guidance, that was supported by foundations. If you're at a foundations roadshow, you'll be able to pick one up off them. If not, I think you can order them online. They're free. Fantastic guidance for occupational therapists, written in a really clear and understandable way. I'd certainly recommend you all get a hold of one. And the reason I put the purposes on here, I'm not going to go through them all, but often my experience of supporting occupational therapists or supervising occupational therapists, when they get themselves into trouble in terms of or just confused, I mean, rather than trouble, get themselves confused about what they should be doing, it's because they've made that jump to necessary and appropriate without actually seeing does it meet one of the purposes. So for something like accessible bathroom design, access to a wash basin, access to bath or shower, access to toilet, yeah, clearly no problem. It's hit a purpose. Now I can go to necessary and appropriate. If it doesn't hit one of those purposes, no point in going to necessary and appropriate because it won't be funded. It can't be funded. It's remembering that DFG is a means to an end. We're not assessing for DFG. We're doing the assessment, the occupationally focused, client-centered, holistic assessment, and then we are seeing how best to meet that need. And DFG is one of those means. We're not assessing specifically for DFG. So there could be things that are out with DFG that we still need to resolve. So purposes comes first. And then we're providing guidance on necessary and appropriate, remembering that we're not the decision makers. Housing make the decision. We are providing a recommendation. So the next thing I see is that people get very annoyed or frustrated around our recommendations not being implemented. And yes, that's fine. We understand from a client perspective, we can be frustrated, but we need to acknowledge that the decision isn't ours to make. We're making recommendations. If anybody on the webinar is from housing, yes, it's your decision to make. Occupational therapists, I'm talking to here as an occupational therapist, it isn't ours. We're making the recommendation only. Remember that people with degenerative conditions who might have further adaptations might become necessary at a later date. There's no restriction on successive applications for DFG at the same property. In such cases, previous contributions will be taken into account. So even if somebody has a nil award, it could well be within their benefit to still apply because that could impact future awards. And then that's the question that I started to ask earlier. So how do we support those who are self-funding? So if somebody screens out from a means test perspective, it doesn't end our duty of care. We don't then just well, we do often, and I see it. We provide someone with a list of contractors. There you go. It doesn't absolve an authority of responsibility just because someone screens out from a means testing perspective. It just means you can't use DFG. So from a service perspective or from an individual therapist perspective, just consider there what you and your service do if that person ends up being self-funding. Approved DocM, so it provides minimum standards for accessible design for new builds and major rebuilds or major adaptations and covers all of those areas. We're not going to go into this in an awful lot of depth, but I'm providing, if you weren't aware of it, the information that you can go and find. Approved.k, which is lesser known. It does the same thing, provides minimum standards, but for things like stairs, steps, landing, floor materials, ramps, and windows, and it's around falls, collision, and impact. So whereas Doc M is around accessibility, K is around falls, and it's one of the lesser referenced by us, I often find. So maximizing independence and dignity, how do we do that? Through empowerment, and by that I mean things like teaching, strategies, education, an MDT approach. I know we always say MDT approach, but it's around true collaboration. So working collaboratively with occupational therapists, physiotherapists, contractors, people who are installing these works, social workers, everybody who could be involved to support that person. And contractors are a key part of that. Architects, the people who are designing these spaces, companies like Closomat. What we should be is the expert in occupational therapy. Again, I'm talking to occupational therapists. We are key, we are the experts in occupational therapy. And our part within that should be our understanding of the person, our ability to communicate the activity analysis and make recommendations on what's going to support that person to engage in meaningful and purposeful activity. That's going to be different input to a physiotherapist, to a contractor, and to a social worker. But to get that whole environment right, all of those people need to be well informed. Technology and innovation. So there are other things that are available, such as voice-activated devices and smart home adaptations. Let's get to know them. Let's get to know how we justify them. They're able to be funded through the DFG. So and the guide that I talked about, the foundations, talks about them in a lot more detail. With some really good examples and case studies that you can use then to justify your own position for your client. And support networks. Do we know what charities exist? I've already talked about versus Arthritis, who are a fantastic charity and do some great work. But there are others, and peer groups that we support the person to engage with. Remember, a well-designed environment doesn't just improve function, it improves quality of life. So this isn't just about always providing that basic. As occupational therapists, we cover need, want, and expectation. So there are all always opportunities to meet that need, want, and expectation. It might impact who funds what, but as occupational therapists, we need to be considering that all of the time. Thank you.